I stopped making roller barges for packing abscess cavity about 15 years now. So, how do we approach an abscess? Principles of abscess drainage lie in the fact that you have to see whether the internal opening is there or not. If the
Good evening, friends. We warmly welcome all of you for today's PG clinics. We have two students kindly accepted to present the patient's history and clinical discussion here. One is kindly contributed by Professor Hidavu sir from Nagpur, and the other candidate is contributed by Professor Ishwar sir and Guru Shantapa sir from KIMS Hubali. Yash Jain will be presenting first a case of the carcinoma breast, and then followed by Dr. Jay Sudha will be presenting next. She'll be presenting a case of carcinoma penis. So, good evening, everyone. Nanan sir, good evening, sir.
Good evening. Good evening to you.
Please,
Thank you.
they don't heal because you read the.
Maybe I request people to mute other gadgets, please. So, friends, we have both the students logged in. We'll have the carcinoma breast candidate first. Professor Dr. Yash Jain, can you try sharing your PowerPoint? Please introduce your unit chief, your head of the department, and start your presentation. You will be non-stop going till the history, end of history. After that, you go back to the first slide and the faculty will be asking questions. All right. Good luck to you.
Sir.
All the best. Make it full screen.
So is my skin visible, sir?
Yes, we are not able to see the full screen. You are able to see your PPT. Press the F5. Yes.
Yes, sir. I have pressed the F5 button, sir. It is full screen in my screen.
Wait, then I'll let you check with others.
Go to slides show.
Is it full screen, sir, now?
Yeah.
Yes,
It is,
yes,
sir.
yes.
It is.
Now we got it.
Yes.
Please start, Dr. Yash. Please introduce yourself, your chief, and then start it.
Good evening to everyone. Myself, Dr. Yash Jain, a junior resident in GMC Nagpur. I am doing this presentation under the guidance of Dr. Brijesh Gupta, sir, who is the HOD of General Surgery Department in GMC Nagpur. Dr. Abdul Qureshi, sir, who is a professor in GMC Nagpur Department of Surgery. And Dr. Gayatri Deshpande, ma'am, who is a senior faculty in Department of Surgery in GMC Nagpur. Should I proceed ahead, sir, with my case presentation?
Please go ahead. Faculty,
Yes.
please take over.
A 42 years old female patient, homemaker, residing in Nagpur, presented to surgery OPD with chief complaint of lump in the left breast since last 4 months. The patient was apparently all right 4 months back when she first noticed a lump in her left breast of approximate size 4 into 5 centimeters. The lump has not increased or decreased in size since then. It is a painless lump and is not associated with any nipple discharge. There's no history of any changes in the nipple or alveolar complex. There's no history of any similar complaint in the family. There's no history of bone pain, cough, breathlessness, abdominal distension, or headache. There's no history of fever or pain associated with the lump. There's no history of any trauma to the breast. There's no history of any swelling in the opposite breast or axilla. Menstrual and obstetric history. My patient attended MENAR at the age of 14 years. We're currently premenopausal with last menstrual cycle period of 25th of September. Menses are regular, last for 3 days. My patient has 2 living issues. First child at the age of 23 years and second child at the age of 26 years. All were breastfed. Family history, there's no history of similar complaint in the family. No history of any other malignancies in the family. Past and personal history, bowel and bladder habits are normal. Sleep is normal. There's no history of any other medical condition like diabetes or hypertension. There's no history of any surgery in the past, and patient denies any addiction. My case summary, a 42-year-old premenopausal female with a case of lump in the left breast since the last 4 months with no history of metastasis or positive family history.
Can you just go to your first slide, please? Yash. Can you go to your first slide? Can you hear me?
He has some issues with the internet, I guess, ma'am.
Is he able to hear us? I don't know.
Yash,
He's frozen.
he got disconnected. Both.
So was my history audible, sir, or should I repeat
No,
the
it was audible. You go to your first slide, Pa.
Yes, ma'am. I will connect to my screen again, ma'am.
Yeah, please.
Now can you see the case summary, ma'am?
Yes,
Please
you
go
go
to
to
the
the
first
first
slide, yeah.
slide. First slide, please.
Yes, ma'am. Just a minute. There is some glitch from my side, ma'am.
No worries, no worries. No
Extremely
worries.
sorry,
No worries.
ma'am.
Okay. Go to the next one, please. See, before you go to your present beginning was good. Your thought about the lump, the size, everything. Before you jump to the metastatic symptoms or family history,
Yes,
you have to say very important things about the ipsilateral breast and the opposite breast. Same, I mean, the left breast and the right, isn't it?
yes.
So, you have to say whether she discovered any other lump in the same breast. It's important. Sometimes when they examine and they find one lump, they will find another lump incidentally. So
Yes,
the same breast as well as in the right breast, did she notice any lump? And lump in the, any swelling in the axilla, you said, right? Later on,
Yes.
next slide.
Yes, ma'am. I mentioned it at the end, but yes.
Yeah, better to tell it along with this so that you don't forget to ask as you are presenting. I mean, it can be in any order, but you should not miss the point and you should not miss the significance of why you're asking this. Okay.
Yes, ma'am.
And you should also sometimes, some patients will discover lymph nodes in the lower part of the neck. So what is that node? You have to ask that also.
Yes, ma'am.
Yeah, supraclavicular.
Supraclavicular lymph nodes.
They noticed a swelling in the lower part of the neck after they notice a breast lump. So it is up to you to ask the question. If she says yes, fine. Otherwise, you note it down. Okay.
Yes,
So
ma'am.
everybody likes to ask trauma to the breast. What is the significance?
Sir, ma'am, it usually brings notice the patient about the lump to start with.
Yeah, that may be true for a hydrocele, but not exactly to the breast. It is usually discovered while they're having a bath or, something like that. But
Yes.
trauma to the breast can cause traumatic fat
Traumatic
necrosis.
fat necrosis.
Could be
ma'am. Yes.
mistaken for a malignant lump, but it's extremely rare. CA breast is more common than
Traumatic fat necrosis.
So whenever you ask a question, you should know why you're asking the question. If the answer comes this way, what do I do with this answer? So specifically you're asking, all right. And then you go back to the previous slide. Yeah. So you're asked about metastatic symptoms, right?
Yes, ma'am.
All right. Abdominal distension is due to what?
Ma'am, maybe due to ascites, ma'am. Abdominal distension.
In this
Again,
lady?
any
other
organomegaly. It is she's a premenopausal lady, ma'am. So pelvic mass, ovarian mass.
Yeah,
can cause,
exactly.
abdominal
Organomegaly means be very specific. Say you're suspecting what? Hepatomegaly.
Hepatomegaly.
Right? And
Yes.
pelvic mass, is she aware of any lower abdominal mass?
Yes, ma'am.
All this may lead to abdominal distension. So when you're examining, you should be carefully looking for all these things.
Yes,
And then you have just said no malignancy in the family. So kaun-si malignancy you asked? Which one did you ask?
Ma'am, I asked for breast malignancy in the family, ovarian malignancy, GI malignancy like stomach malignancy or pancreatic malignancy. In paternal side, a prostate malignancy is important, ma'am.
So suppose they say yes to a couple of these questions. So what does it really mean to us?
Ma'am, this could be, a hereditary breast carcinoma.
Familial, okay?
Yes, ma'am.
Or very rarely it could be a BRCA mutation, but it's
BRCA
pretty
mutation,
rare.
yes.
But they can be a familial history of CA breast or CA ovary, need not be BRCA every time, but
Yes.
better to keep note of that. And so this increases the risk for this lady, for this lump to be a malignant one.
Malignant lump.
That
Yes.
is what you keep that history in mind for. Okay.
Yes.
And go to the next one. I'll just finish, sorry, then anybody else can make the comment. So when is a breast lump painful? Give me examples of painful breast lumps.
Ma'am, any inflammatory benign breast lump can be painful, like in the case of mastitis or in case of abscess, there can be a lump and it can be painful, ma'am. Even traumatic fat hematoma is painful, ma'am.
Okay, all that is there. But suppose this lump is slowly increasing in size after 6 or 8 months, it becomes painful. It is painless to start with, now it becomes painful. So what does it signify? The same 42-year-old premenopausal lady, suppose a lump is there, slowly increasing in size, 6 to 8 months. Then after some time, it becomes painful. So how will you interpret it as? Okay, it could be infiltrating the skin. It could be a malignancy infiltrating the skin. Then they get pain, or it is getting fixed to the underlying chest wall. Then there may be some discomfort, not exactly pain. So you should always keep that in mind when you ask question about pain. Okay. Anything else other examiners can ask? Thank you so much.
Thank you.
Dr. Yash,
Yes, sir.
how many siblings does she have? And did you take a family history? You said you took a family history. Any idea about how many siblings she had? You said you asked about ovarian cancers, colorectal cancers, stomach cancer.
Yes, sir.
You should also ask how many siblings she had. Isn't
Yes.
it?
Yes, sir.
What percentage of breast malignancies are due to genetic mutation?
Sir, hereditary breast carcinoma accounts for 5 to 10% of all breast cancer, sir.
So only about 5%. It's usually only around 5%. And why did you ask for fever and pain? You said fever and pain, any particular reason?
Sir, and to rule out any inflammatory lesion, sir, like an abscess.
But you said it is painless, no?
Yes, sir, it is a painless swelling. Painless lump,
specifically fever and pain for any particular reason?
So nothing apart from inflammatory.
Inflammatory. Are you thinking in terms of mastalgia due to Andy or?
Yes, sir. And associated with fevers are inflammatory cause.
No, are you thinking in terms of benign breast diseases?
Yes, sir. To rule out any benign breast disease, so non-inflammatory.
Non-inflammatory. Okay. What changes in nipple and areola did you ask for? You asked in the history. I mean, you specifically mentioned there in the history.
Yes,
no
sir.
History of any changes in the nipple and areola. What did you ask for?
I asked for ulceration. I asked for redness, eczema. I asked for if there is a redness, the itching. Sir, to rule out any Paget's disease, sir, if there is destruction of nipple or there is involvement for involvement of nipple areolar complex, sir, like is seen in malignancy.
Yeah, what is the involvement that you would see if
nipple retraction?
Nipple retraction, isn't it?
Yes, sir.
Nipple retraction is probably what you can ask for.
Yes, sir. Yes, sir.
You can ask for nipple retraction. You could ask for some nipple discharge.
Discharge, sir. Yes, sir. I asked for
it. But history of ulceration or in the sense that it's unlikely to heal if it is a Paget's disease. It's not likely to heal, isn't it? You said Paget's disease specifically.
Yes,
so it is unlikely to regain the normal surface. If it's a Paget's disease, it's likely to be likely to remain there. The change is likely to remain there. What sort of a discharge do you expect?
Sir, sorry, sir.
What sort of a discharge would you be more interested in?
Sir, blood stain discharge or serosanguinous discharge?
Serosanguinous or blood stain. What about bloody discharge? When will you get a bloody discharge?
Bloody discharge can be seen in case of ductal papilloma, sir.
Papilloma, more in case of benign disease, isn't it? Huh?
Yes.
So you
Yes.
would ask for more of a serous discharge or a serous sanguineous discharge.
Pseudosanguinous.
Yes, sir. So history for nipple discharges. And when you say history of changes in the nipple, changes in the areola complex, you ask for nipple discharge also. Okay.
Yes. Yes.
Right. Any skin changes? Did you ask for any? She doesn't give any history to suggest any skin changes, isn't it?
Yes, sir. No ulceration.
No ulceration. Only thing she has noticed is a
Lump.
lump. So at the end of the history, what
Yes,
do you
sir.
think? What do you think this could be? What
Sir,
is a 42-year-old lady?
Sir, at this age, a first differential diagnosis is to rule out a malignancy, sir. A lump, female presenting with a lump, we have to think about malignancy first.
Malignancy. You would like to think about malignancy, isn't it? How is the menstrual history important?
Menstrual history is important. One is it tells about the risk factor associated with breast malignancy.
Yashal, what is the difference between a hereditary breast cancer and a familial breast cancer?
Hereditary breast cancer, they are usually attributable to So hereditary breast cancer is usually associated to a genetic attributable risk, usually bilateral and multicentric, presents in younger age group. In case of a familial breast cancer, it is present in many members of the family, and it is not attributable to any genetic cause.
Okay. So what are the various risk factors is present in your patient?
Sorry, sir?
What are the various risk factors of the breast cancer present in your patient?
The age of the patient is 42 years, sir.
So is that a risk factor?
In India, sir, the presentation of malignancy is usually premenopausal at earlier age. So it is one of the risk factors, sir.
Yes.
Then,
what other risk factors are there?
Sir?
What other risk factors are there in your patient?
In my patient, there were no menstrual risk factor or history of any medical medications or any family history also, sir. So no other risk factor I could find in my patients.
Do you know what are the various absolute risk factors and what are the relative risk factors?
Yes, sir. In absolute risk factors are there are 5 to 6 absolute risk factors, sir. Like BRCA1, BRCA2 mutation. There is history of breast cancer in the opposite breast, sir. Family history of breast cancer. Age is an absolute risk factor, sir.
And sex is the risk factor. Female is the risk factor.
Yes, sir.
Any benign breast disease which is a risk factor?
Sir, atypical lobular and ductal hyperplasia.
So did you take the history of any breast surgery in this patient?
Yes, sir. I ruled out any surgery in the past in personal history, sir. I asked for any history.
No, not any surgery. Surgery on the breast.
Yes.
Okay, you have to specify that there is no past history of surgery on the breast.
Okay, sir.
What are the various modifiable risk factors?
The modifiable risk factors are obesity, tobacco and alcohol consumption, use of hormonal replacement therapy.
Yes. More modifiable risk factor.
Obesity, radiation exposure, and child at first child at what age?
Lady living in the USA and lady living in India. Is there a difference?
Yes, sir. Western.
What is the difference?
Sir,
What is the prevalence of breast cancer in American lady?
sir, it is more in the American side than India, sir.
How much is that more?
I don't know, sir.
It's around 6 to 8 during her lifetime. And in India, how much is that? What does the ICMR study says? It's approximately 21. Okay, so
Yes, sir.
living in the different countries also, so environmental factor is also there.
Yes,
So
sir.
those are all the modifiable risk factors. Okay. Dr. Lal, you can ask.
No, it's a good presentation, but there is an order in which you need to go. Suddenly, you are there's no similar comparison history, and the same sentence you are going to repeat in the family history also. And what is the need that we are putting that family history in the present history?
Yes, sir.
Hello.
Hello. So, sorry, sir. I was not able to hear you, sir. Hello.
No, you are putting the similar complaint in the family in the present. Is there any reason you are putting that as in the present history? Because you are you are saying that same thing in the family.
Yes, sir. Sir, actually, I thought of putting etiological history in the initial part, but yes, sir, I should have corrected that, sir.
You have asked the history of trauma. Then what kind of trauma you are expecting which will cause fat necrosis?
Sir, shearing force, like in case of seat belt injury, sir.
Must be a continuous process. What is the pathogenesis of the fat?
Hello, sir. Liquefactive necrosis of the fat.
Liquefactive necrosis.
Yes, sir.
Which is good, actually.
Hello, sir. Am I audible clearly, sir? Because I am not able to hear properly, sir. Hello.
No, what is the pathogen?
Yes, there is some connectivity problem.
Necrosis.
Ma'am, am I audible clearly, ma'am?
No, you are audible, but there is some connectivity issue.
Okay, go ahead then.
Maybe Professor Jailal.
Should I go with the examination, ma'am?
Only one question from my side, Yash. This is Dr. Ibrahim, surgical oncologist.
Yes.
So one thing I don't agree with you here is in the main history you are telling, the patient was apparently normal for 4 months. From that time, there is no increase or decrease in size.
Yes, sir.
And it was painless. So what is the reason why the patient has not come all these 4 months? And what is the reason why she has come to you at this moment? So there should have happened some acute event. So what is that event?
Sir, when asked, she just she didn't complain of any pain or anything, sir. And also she ignored the lump for the last 4 months. And yes, sir, no particular reason, sir, like a pain or something that would have drawn her to come now.
So you should. So in your clinical examination or in your practice, you should always concentrate on that. Because
Yes,
why
sir.
she has not come for all these 4 months, and you are telling that there is no increase in size, no decrease in size, no new. Now, some is not telling. Right?
Yes, sir. Yes, sir.
Can go with examination.
Yes, sir. General examination. Patient was examined in a well-lit room with proper exposure, due consent in the presence of a female attendant. Patient is conscious, oriented to time, place, and person. Pulse rate was 74 beats per minute in the right radial artery. Blood pressure was 120 by 80 millimeter of mercury in supine position. Saturation was normal on room air. A BMI of 26 kg per meter square with no evidence of pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. This is the clinical photograph. I would skip the photograph. Inspection. On examination in the sitting position with arms by the side, there is slight bulge seen in the upper inner quadrant of the left breast with left nipple deviated slightly lower and outer. On bending forward, both breasts fell forward. On raising arms above the head, left nipple seen at lower level than the right with no visible swelling in the axilla. No dimpling of the skin was seen. Both the nipples were normal with no retraction. Areola was normal with no redness or destruction. Skin over the swelling shows no redness, edema, dimpling, or dilated veins. There is no evidence of powder orange, nodules, or any ulceration. Palpation, all inspectory findings were confirmed. There was no local rise of temperature or tenderness. Sir, am I audible, sir?
You're audible. You're audible.
Yes.
The right breast was
You're
normal.
audible. You go ahead.
Yes, sir. Sorry, sir. There was a single palpable lump of size 5 by 5 centimeter in the upper inner quadrant of the left breast, globular in shape, well-defined margin, irregular surface, hard in consistency, with no nipple discharge. Fixity to the breast tissue was present. Overlying skin was pinchable. There is no fixity to pectoralis major or chest wall. There is no evidence of lymphadenopathy in axilla or neck on either sides. On systemic examination, CVS, cardiovascular examination, S1, S2 was normal. On CNS examination, patient is conscious oriented. Per abdominal examination was soft, non-tender with no organomegaly. And respiratory examination, air entry was equal bilaterally. My diagnosis, a case of lump in the left breast, probably malignant in origin with a staging of clinical T3 N0 M0, a stage of 2B.
So why do you take it as a malignancy? What are the points in favor of malignancy? Can you summarize?
Sir, yes, sir. Sir, age of the patient, sir, 42 years old. On clinical examination, the lump was, sir, hard in consistency, sir, and irregular margin. There was which favors a diagnosis of malignancy in my case. Though, sir, there were no evidence of lymphadenopathy or skin involvement or nipple involvement. And the breast was fixed to the breast tissue. The lump was fixed to the breast tissue. I have put malignancy as my first diagnosis, sir. Sorry, sir.
No, you have heard about phyllodes tumor?
Sorry, sir.
Phyllodes tumor of breast.
Sir, phyllodes tumor.
Phyllodes tumor.
Sir, phyllodes tumor would have bosselated surface, variegated consistency, sir, with evidence of dilated veins. There can be, so those were not present in my swelling, sir. That's why I have not kept phyllodes as my differential diagnosis, sir.
Any other finding?
Yeah.
Sorry, sir.
Tumor not always will have bosselated. In early phyllodes tumor, it will not have something like that. And next thing is, you have mentioned there is no increase in the size of tumor for 4 months. So again, how will you justify it?
So, sir.
The patient has noticed the lump for 4 months, but still there is no increase in size. So
no increase in size. Yes, sir.
Cause a malignant lump if it is of the same size for such a long duration.
Sir, sorry, sir. Your voice is cutting, sir. Sir, I'm not able to.
You have told that has increased in size for 4 months.
The lump has not increased in size. Yes, sir.
So that means the diagnosis of malignancy.
Sir, sir, at this age, sir, in any female presenting with a lump, sir, of my a malignancy has to be ruled out first, sir. And also, sir, the lump was hard in consistency and fixed to the breast tissue, sir. That is why.
Okay. Such a big lump, T size, you expect nodes or not?
Yeah.
Yes, sir. Notes were not clinically palpable, sir. Yes, sir.
So where location of the tumor, which quadrant it is?
Sir, upper and inner quadrant, sir.
Upper quadrant, where will the drain?
Sorry, sir.
Nodes, which nodes? Upper inner quadrant breast drain which nodes?
Sir, it can drain into the internal mammary is also involved. Usually in when inner side of the breast is involved, sir.
So axillary nodes not involved cannot be accepted, right? So there may be internal mammary node. So how will you clinically internal mammary node?
Sir, usually internal mammary nodes are not palpable, sir, unless it is hugely enlarged, and that too in a female, sir, with thin build female, we will be able to palpate it, sir.
Will you be able to palpate?
Sir, unless it is hugely enlarged, sir, we won't be able to palpate internal mammary nodes, sir.
No, internal mammary, even if it is enlarged, you cannot palpate.
Yes.
So
How do you detect it?
To show that internal mammary is enlarged.
Yes, sir. Sorry, ma'am, you asked something.
Sir is asking clinically, how will you detect if at all the nodes are enlarged? What is a sign or test that you will do? Not palpation, definitely.
For internal mammary, ma'am.
So what is internal mammary?
Ma'am, there can
So
be.
where are the internal? Can you tell the where are the internal mammary? Tell the anatomical location where it stay.
Behind the sternum, along the internal mammary vessel.
So how can you examine the internal mammary vessels or any organ behind sternum? How can you examine it?
Internal mammary.
What is the examination you do after? Yeah, what is the examination you do after palpation?
The systemic examination, sir.
Hey, 4 things in any limb, right? Inspection, palpation. What is the third one?
Percussions, ma'am. Percussion and auscultation.
Examiner gives the hint, take it.
Yes, ma'am. Sorry, ma'am.
Examiner is giving hint, take it.
You have not told. Also, in the systemic examination, you have mentioned respiratory system as the last. You have put CNS as the second. But respiratory system should come first because 2 things are very important. One is parasternal dullness. A parasternal dullness, there is a dullness due to pleural effusion. So, with such a tumor, you can even expect this also. So, you have to examine any storing dullness all over the chest on the right side and also the right. And parasternal dullness has to be mentioned.
Yes,
because patient is sitting on the
inner quad.
Is always the axilla. Yeah, it is not always the axilla. Okay, that has to be kept in mind.
Yes, sir.
Sure.
Madam, you can go ahead, madam.
Okay, because always when the lymph nodes are not palpable, you should have a differential diagnosis or should have an alternate explanation because the size of the lump is 5 into 5 centimeters. T3, isn't it? So
yes, ma'am.
It is, don't assume always you're going to get a CA breast in the exam. It could be even a large calcified fibroadenoma. Of course, it is fixed to the breast tissue. Otherwise, you should consider that also in a lady with no other symptoms, no risk factors as we discussed. So keep your mind open. You're a postgraduate, not an undergraduate. So you have to look at all the possibilities. So you think it most probably it should be a malignancy according to you, isn't it?
Yes, ma'am.
Okay, so how would you want to proceed?
Ma'am, I would like to do a triple assessment in this lady, ma'am. My clinical examination has been done. Now, second is a radiological examination, ma'am. I would like to go ahead with a bilateral sonomammography in this female, ma'am. I would,
Why?
ma'am, first of all, it will, the sonography will tell me about the lump, ma'am, the size of the lump, the vascular,
Why sonography, I'm asking? Why not a digital mammogram, X-ray mammogram?
Yes, ma'am. A sonography will tell me about the lump, ma'am. It will differentiate a cystic with a solid lump. It will tell me
You think
about
this
the
is cystic, pa? You think
No,
this
no,
lump
ma'am.
is cystic? No, you don't talk theory. In this patient, what is the best imaging that you will ask for?
Ma'am, 42-year-old female mammography.
You say digital X-ray mammography. If at all any doubt is there, they will do an ultrasound as a correlation along with it. But primarily, you should not say sonography. You should say a digital or X-ray mammogram is what I would ask for. And what will be the features on the X-ray mammogram? Of course, this is a big palpable mass, but still you'd like to know what are the features that will make you think this is a malignant mass on your mammogram. Can you describe? Yes, I think we have lost you.
Hello. Hello.
We
Hello?
lost you for a couple of seconds. You heard
Yes,
my
ma'am.
question?
Sorry. I'm so sorry, ma'am.
No
Yes,
worries. Tell the
I'm
answer.
good. Sorry, ma'am. I couldn't.
What will be the changes to suggest it is malignancy in a digital X-ray mammogram in this patient?
Ma'am, calcification will be seen, ma'am, especially, ma'am, if stippled calcification are seen, there's irregular margins will be seen on a mammography, ma'am. Then,
Yes, you are talking more of theory. What ma'am is asking is, for this patient with the T3 lesion, what are the mammographic features you expect? What do you see? What do you see? How is the mass? Explain the mass.
sir, if the echogenicity of the mass, sir, if it,
अरे
the,
X-ray mammogram में echogenicity नहीं होता है.
yes,
X-ray mammogram, you should talk about radio dense, radiolucent, or you should talk about something else. Okay, echogenicity is in an ultrasound of the breast. So describe properly.
Since you have told it as a hard mass, what do you
yes.
expect?
Radio opaque, sir.
You expect a smooth margins?
No, sir, irregular margins.
What about the calcification? Will it be there or not?
Some micro calcifications can be there, sir.
What about the vessel calcification? Vessel calcification will be there or not? 42 years old.
Sir, vessel
Come on.
sir, pleomorphic calcification, vessel calcification, sir. No, sir, not.
It can be or it cannot be. It may or may not. No problem. Okay. You just tell. You don't talk theory in clinical examinations. Okay.
Yes.
And what else you want to see? What else you want to see?
What else you'll see?
In the
other than
mammogram, what else
Sir.
you want to see? Why do you want to see that?
Yes, sir. In a end knot disease, which is clinically end knot, I also want to see radiologically, sir.
Dr. Yash, again you're talking theory. In N naught and all, I am not asking about your patient. Tell me in your patient, what are the things you are going to see? Clinically N0. Can you still see a node? Can you still see the nodes, axillary nodes? Can you see here?
No.
So you are not
X-ray
secreting.
mammogram, can you see the axillary nodes?
No, sir.
Yes.
Have you
Ma'am.
ever seen a mammogram picture? Have you ever seen a
Yes.
mammogram picture?
Yes, sir.
What are the views?
How many
Sir,
views
there
will
are
be there?
two views, sir, craniocaudal and mediolateral oblique, sir.
Why do you need two views? Why not one view is sufficient? No, why do you want two views?
Sir, axillary tail is seen in the mediolateral oblique, sir. So that is why
So
we
in
need
the axillary tail, what do you see in the axillary tail?
any lump is seen.
Nodes, can you see or not? Nodes, can you see?
Yes, sir. We can see the nodes.
Yeah, nodes can be seen. Axillary nodes can be seen if it is taken properly. And what else you want to see in this patient? T3 lesion. What else you can see? There's a normal breast tissue also.
Sir?
The lesion is only in the upper inner quadrant.
Yes, sir.
Upper, lower outer, lower inner quadrant, what is there?
So sorry, sir. I couldn't hear you, sir. Sorry, sir.
No, upper outer quadrant, lower outer quadrant, and lower inner quadrant. What is there now? The patient. You have got normal breast tissue, right?
Yes, sir. Yes, sir. Normal breast tissue.
Normal breast tissue. Yeah, that also you can see.
Yes, sir.
If the normal breast tissue is very radio dense, okay, the mammogram may not be used. You cannot differentiate it.
Yes, sir.
In this 42-year-old patient, what do you expect the normal density of the breast? It will be
It will be less dense, sir.
why it is less dense?
So with age, the glandular component of the breast tissue decreases, sir.
Yes. Yeah. Glandular elements will reduce. So the reason why in younger patients you do an MRI breast, not a digital mammogram. Got it?
Yes, sir.
So another important thing you want to see is there might be some non-palpable lesions.
Palpable lesions. Yes, sir.
Non-palpable lesions you can see in the mammogram. So that is very important, because if you are considering a breast conservation surgery, another lesion in another quadrant, you cannot do a breast conservation surgery. Got it?
Yes, sir. Multicentric disease, sir.
Why do you want to screen the breast of the opposite side? Opposite side also you told no.
Hello? Yes, sir.
Yeah.
Hello?
You told bilateral mammogram.
Yes, sir. I will also like to screen the opposite breast and opposite axilla, sir.
Why do you want to see?
So if there is any non-palpable lump in the opposite breast or axilla, which is present, sir.
Yeah. Got it?
Yes, sir.
Yes, what will be the
You can go ahead, madam.
Yes, ma'am. Yes, ma'am.
the lymph node that you see in the axilla and the mammogram, no? When will
Yes,
you
ma'am.
suspect it to be a malignant one?
Ma'am, if the lymph node are mated, ma'am. If there is a loss of hilum, ma'am, loss of
Fatty hilum, correct.
fatty hilum. Yes. If vascularity is no, not on a mammography, ma'am.
Vascularity and all, you cannot comment.
Not on a
Mammogram.
mammography, yes, ma'am.
Yeah, and sometimes a node will become rounded. Okay.
Round, yes, ma'am.
And there'll be irregular cortex. The outline will be very irregular. Matting may or may not be there. There's a loss of fatty hilum is an early indicator that this could be a malignant node. So that is the importance of looking at the mammogram properly. So impalpable nodes sometimes can be visible on mammogram. All right.
Yes,
and architectural distortion. Okay. Calcifications plus or minus, and other lumps, as sir very nicely said. In this day and age, don't assume we'll land up with a mastectomy for this patient. Okay, there are options available for neoadjuvant and breast conservative surgery. So you have to think on those lines.
Yes.
Thank you. Suppose this comes as Beirat's 4C or.
Yes, ma'am. That is highly.
So what does Beirat's 4 mean?
Sir, ma'am, Beirat's 4 stand for breast imaging and reporting, breast imaging reporting and data system, ma'am.
What does it mean? How do you interpret it?
Ma'am, it tells about the risk of
this Beirat's 4 ki matlab kya hai? Bas.
It tells about the risk of malignancy in the lump, ma'am.
See, they will say Beirat's 4 means strongly suspicious of malignancy, advise biopsy.
Yes, 4C is highly suspicious of malignancy.
5 means it is malignant.
Suggestive of malignancy.
Okay.
Yes, ma'am.
6 is when you're doing a mammogram, after the biopsy has been done.
Biopsy.
So when you say 4C, it is strongly suspicious. So what will you do next?
Ma'am, I would go for a guided true core needle biopsy in this female, ma'am.
Yes. Don't say female pa, say lady pa.
Lady, sorry. Core needle, guided core
This way
needle.
you should present it.
Yes.
Core needle biopsy, ultrasound guided preferably.
Yes,
So
ma'am.
that you go and target the correct area. Okay. So ultrasound guided core needle
Core needle
biopsy.
biopsy. Yes, ma'am.
Okay. That comes as infiltrating ductal carcinoma, triple negative.
Yes, ma'am.
So what will you do? KI67 is
High.
48%.
High. That is high. Ma'am, I would. Hello.
You carry on. Continue, Yash.
Yes, ma'am. I would go for a metastatic since it is a T3 lesion, ma'am. A metastatic. I would go for.
Okay, before that, Dr. Kanagavel, sir, can you please mute people who are. Okay.
Yes, ma'am.
Okay, so before you go to metastatic workup, I just what is that? Anything else that you want to look at? Anything else in the biopsy report you would like to get information?
Ma'am, I have gotten information about the invasiveness. I have gotten information about the immunohistochemistry, which is triple negative. Then it is a high, then grading of the tumor, ma'am.
I didn't mention that. So you have to ask for the
grade of the
tumor. That's very important.
Yes, ma'am.
And don't you want to know what is a pathological type of the tumor? Because sir was also asking opposite breast, remember?
Yes, ma'am. Histological type of the tumor is the first.
Which is the most common histological type?
Ma'am, invasive ductal carcinoma is the most common type, otherwise specified.
Not otherwise specified, correct.
Yes, ma'am.
So you should get all the information. Grading, you go back and read how do they do the grading and all.
Bloom,
every information you get, what is it importance to know whether it's triple negative, KI67, grade? Why do you need to know so much?
Ma'am, if I'm planning the patient for a neoadjuvant chemotherapy, then I want to have a immunohistochemistry so I can get the hormonal if I'm targeted therapy, ma'am.
Yeah, not only because you're planning neoadjuvant, in every patient you need to know this so that the overall prognosis, it's called prognostic factor as well as predictive factor. So prognosis, whether this will respond to the treatment, all the information you will get. So upfront, you should have everything before you talk to the patient and plan the management. So this understanding should be there. Okay.
Yes, ma'am.
Then metastatic workup, what do you want to do? What is the stage you said? 2B, huh? Okay.
Yes, ma'am.
What metastatic workup you want to do?
Ma'am, I would like to do a chest X-ray, ma'am. X-ray of the thoracolumbar spine, ma'am. Sonography of abdominal and pelvis, ma'am.
What you hope to see in the X-ray of the thoracolumbar spine?
Ma'am, if there is any osteolytic.
Is there any other better way of imaging it?
Yes, ma'am. Bone scan is a better way, ma'am, and a contrast enhanced thorax plus abdominal with pelvis.
Okay, so if you look at what is that? NCCN guidelines.
Yes,
okay, for an early stage CA breast. Okay, all you need to do is get a chest X-ray, get a liver function test, get an ultrasound abdomen to look at the liver, ascites, and in this lady, the ovaries. If she's symptomatic, back pain, everything, then you go for an isotope bone scan. Otherwise, if there is a change in the X-ray, then go for a CT chest. They do not ask you to do PET. They do not ask you to do isotope bone scan. So these guidelines are established with a vast experience in various things. So don't over-investigate the patient.
Yes, ma'am.
Okay. So early stage CA breast, this many investigation is okay. But patient has got extra symptoms and definitely that area has to be imaged. I hope Dr. Mohammed will agree with this. Okay?
Yes, madam. Yes, madam.
Thank you.
Yes, can you just tell me how you will do a core needle biopsy? How you will do? What will be the location of insertion of the needle in this patient?
Sir, core needle biopsy will be done ultrasonography guided, sir. I will at least say 5 to 6 throws of core needle biopsy and from the solid component. And it should be in alignment with the my plan of incision, sir.
Correct. So it will be done under local anesthesia, general anesthesia, or no anesthesia?
Local anesthesia, sir.
What about FNAC? FNAC you do under local or no anesthesia?
FNAC, sir, it is a no anesthesia.
FNAC you don't need an anesthesia. You just get a consent and do it. But for this thing is very important. So most of the time we see patients undergoing core needle biopsy from opposite quadrant. You got it from the opposite quadrant. So that is for this patient. Sometimes what happens is the ultrasound, because you tell it as ultrasound guided, the ultrasound probe will be kept in a place in an adjacent quadrant. And from there, they will be inserting the needle. So that should not be done. So it should be done, as you said, it should be included in the future incision. If you are planning for a breast conservation surgery, it should be included. If it is a modified radical mastectomy, that biopsy site has to be included. So that is very important and it has to be marked there. And what else you want to see? You told about bone scan and other things, X-ray lumbar spine, but we were discussing about internal mammary nodes, right? So what is the investigation of choice to look at internal mammary nodes? What is the investigation of choice?
Sir, CCT thorax.
Yeah. So that should be the first investigation. Instead of just X-ray, lumbar, LS spines, X-rays. So CT, even though it is some people consider it as an early breast cancer, I will call it as an operable locally advanced breast cancer. So early breast cancer is T1, T2, N0, N1. So here, once it comes to T3, even though the composite staging is 2B, it is an operable locally advanced breast cancer. So you can go with the neoadjuvant chemotherapy, or you can go ahead with the primary surgery based on the investigations.
Yes.
Suppose it may be clinically operable, but in the investigation, you see an enlarged parasternal node or an internal mammary node, you will definitely not operate. You will go ahead and do a neoadjuvant
chemotherapy, sir.
Yeah. So now I'm having only one question. So if you are planning to do a neoadjuvant chemotherapy, why do you want to know the receptor status before the chemotherapy? Because anyhow, after the surgery, you are going to remove the tumor, no? So you can get the better profiling later. Why do you want it before starting the chemotherapy?
Sir, if the patient is HER2 positive on receptor status, a neoadjuvant chemotherapy can be planned accordingly. Trastuzumab can be added, sir, later on. Also, sir, after the surgery, the immunohistochemistry status after the neoadjuvant chemotherapy, the IHC status, sir, it is better to get before starting giving chemotherapy, sir.
Yeah, why?
Sir, after receiving chemotherapy and this immunohistochemistry status get this.
Yeah, go ahead.
They get this. I'm not able to find it. They get the results are not.
It can change.
It can
change. Yeah, hormone positive receptor tumor can become a hormone negative receptor tumor after chemotherapy. So that's why we always do. So it is both for documentation of the original tumor. It is also for planning the drugs. What chemotherapy? If it is a triple negative, go with Taxol and carboplatin. If it is a hormone positive, you can go with doxorubicin and cyclophosphamide. So to select that chemotherapy regimen and also whether to include targeted therapy or not, and also to document was the initial IHC status of the initial tumor. So these are the reasons why do you want to document it prior.
Yes, sir.
Yeah, go ahead.
So
what is the management of this patient now?
Yeah, we assume the staging investigation is negative. And how will you manage?
Since it is a T3 lesion, ma'am, I would go for a neoadjuvant chemotherapy in this patient and then check for response in this patient.
After how many cycles?
After 2 cycles, I will check the response.
No,
3
no,
weeks
no,
after.
not 2 cycles. No. Minimum 3, ideally 4. Okay.
Sorry,
Somewhere
yes,
between 3 and 4 cycles. After that only you have to check the
check for
response.
response.
How will you
Yes.
check the response and what are the different responses?
Ma'am,
How will you
there
check
is
for
a
the response?
ma'am, there is a RESIST criteria, ma'am. That is response evaluation criteria in the solid tumors, via which I will check the response. There are 4 subtypes, ma'am. Complete response, partial response, stable disease, and progressive disease. Uh,
How will you assess this?
so, ma'am, clinically and radiologically.
Okay.
So clinically, now the lesion is, what is now the initial size of the lesion?
Ma'am, the initial size of the lesion was 5 centimeters.
So 5 centimeter. Now the lesion becomes 3.5 into 3.5 centimeter. What is the RESIST outcome now? Which category
Sir,
does it belongs to?
it is a partial response tumor, sir. There is more than 30% decrease in the size. Hello.
Okay, but at the same time, I am seeing a node in the axilla now. What does it mean?
Node in the axilla. Sir, it means it is a progressive disease, sir.
Yeah. So you told only the size criteria. So in the RESIST criteria, not only the size matters, but also no appearance of new lesions.
No appearance of new lesion. Yes.
So if the lesion decreases in 3.5 centimeter, but suddenly you see a skin satellite nodule, then it is progressive disease.
Yes.
You
Sir.
see an axillary node, it is progressive disease. You see a supraclavicular node, it is progressive disease.
Yes. Sir.
So RESIST does not depend only on the size criteria alone. Okay, go ahead.
So accordingly, sir, if it is a complete response or partial response, or whether it is a stable disease and progressive disease, I'll go ahead. I'll further plan the management of this lady, sir. If it is a complete response or partial response,
Yeah, now it is 3.5 centimeter. Tell me what is your surgery? What is your plan?
no new nodes, no new lesions, sir. It is a partial.
No lesions.
Sir, it
Yeah,
is a
no
partial.
new lesions. Now what is the
It is a partial response, sir. I'll complete the neoadjuvant chemotherapy for this patient and plan for a breast conservation surgery for the patient.
Okay. So what to do in the breast conservation surgery?
Sir, I would do a wide.
You want to do any other investigation? Any other investigation before contemplating breast conservation surgery in this patient?
Sir, a sentinel lymph node.
No, sentinel lymph node biopsy is a surgical procedure. I am asking what any other investigation.
Sir,
you told you will assess the size clinically and radiologically. So what radiological investigation you want to do?
Mammography, sir.
So what do you expect in the mammography? What do you see?
So there will be a decrease in the size. I'll look for if diffuse microcalcification is present, sir. If I'm planning for a breast conservation.
No. You are again talking theory. So what you're interested in is the size. So clinically,
Size,
you
yes.
see the size reduced from 5 centimeter to 3.5 centimeter. You want to confirm
Yes.
it radiologically also.
Radiologically.
Whether
Yes,
the tumor has shrunken by 5 to 3.5 centimeter. And another thing is, whenever you give neoadjuvant chemotherapy, not all tumors will shrink in the concentric manner. There might be some eccentric shrinkage also. So the main tumor in the center of the tumor may reduce to 3.5 centimeter, but surrounding areas you can see lot of daughter clusters. So that is because of eccentric reduction in the size of the tumor. So if there is an eccentric reduction in the size of the tumor, you have to give the margin based on the primary tumor, that is prior to the neoadjuvant chemotherapy. If there is a concentric reduction in size, you need not give so much margin. Got it?
Yes, sir.
So whether you are seeing a concentric reduction or an eccentric reduction,
Eccentric
that can be
reduction.
seen with the mammogram.
Mammography.
So that mammogram has to be compared with the mammogram film, not the mammogram report, but with the film of the previous prior to the neoadjuvant chemotherapy. Both the mammogram has to be seen by the operative surgeon. So
Yes,
they
sir.
have to decide it is a concentric reduction or an eccentric reduction. So based on that, you will plan the surgery, whether it is a modified radical mastectomy or a breast conservation
Breast
surgery.
conservation.
So now there is a concentric reduction. So you are planning to do a breast conservation surgery. How you will
Yes.
do that? Tell me.
Sir, I will do a
How
wide.
you will do the breast conservation surgery?
So I will do a wide local excision with 1 centimeter margin, sir. I would take a transfer.
So where you will give the 1 centimeter margin?
Sir, all around.
Where you will give
All
the
around. In all the.
or it is three-dimensionally all
It has to
6
be
sides.
three
Okay?
dimension. That's about your
3 dimension. Yes. Oh, yes, yes, ma'am.
And tell me about the skin. You told transverse. What is the incision you are going to use? Tell me.
I will take it along the line.
Think and answer.
Line of I'll follow the line of Kaisel, sir. It runs transverse.
Okay.
So which is
We were
cosmetic.
discussing about the true cut biopsy scar. What you are going to do with the true cut biopsy scar?
I'll include that in my incision, sir.
Yeah, so it is not a first incision, typical incision. You have to encircle the true cut scar.
Hello.
The skin true cut scar. You took a core needle biopsy, right?
Yes, yes, sir.
So that core needle biopsy, the skin around the core needle biopsy scar has to be excised in toto along with the tumor.
Along with me.
So you have to tell it as a transverse scar or an elliptical scar encircling the scar of the core needle biopsy. Yeah. Then what else you do? You do a wide excision. What else you do then?
Sir, I will do the marking on the specimen, sir.
Okay.
Then along with that,
if you are so slow, the patient will get up from the anesthesia, man.
a sentinel lymph node biopsy will be done, sir.
You want to do a sentinel lymph node biopsy after removal of the tumor?
No, sir. Before removal of the tumor, sir.
Then you didn't tell that. So at least you inject a dye. So if you are planning to do a sentinel lymph node biopsy, you have to inject the dye peritumorally.
Yes, sir.
Okay, then you do a wide excision. In the meantime, the dye will
travel to the sentinel lymph node, sir.
So where do you expect the dye to travel? Where you can get the sentinel lymph node here in this patient?
This is present in the inner quadrant, sir.
So
in internal.
So the dye will travel to the internal mammary node, and you will be opening the axilla and looking for the dye. No dye will be there. So what's your plan now? Are you able to get my question?
Yes, sir.
Yeah. So you cannot get the internal mammary node dissected by axillary dissection.
Yes, sir.
Or any other surgical procedure. So what you can do is you can do with go ahead with the regular classical axillary dissection with removal of level 1 and 2 lymph nodes. So what will happen to the internal mammary nodes? How you will treat the internal mammary nodes?
Sir, post surgery chemotherapy and radiotherapy, sir.
Yeah, so that is very important. So yes, it is always not the surgery going to treat the patient. It is multimodality treatment. So there are some places which you cannot. which you cannot resect surgically. So in this patient, if you are contemplating for a breast conservation surgery, you have to do a wide excision and an axillary dissection. Now tell me how you will close the wide excision, because it is such a big space, no? 5 into 5 centimeter. Now you have reduced to 3.5, but you are giving 1 centimeter margin all around. So when you give 1 centimeter margin all around, it is a 5.5 into 5.5 centimeter cavity. What you are going to do with the cavity?
Sir, there is an oncoplasty procedure, sir, which should be done in the same setting, sir.
What does that mean?
Sir, either the volume.
What does that mean?
A volume displacement or a rearrangement volume oncoplasty can be done, sir, in the same setting.
Okay. So in upper inner quadrant, the glandular elements will be more or less. Will become maximum glandular elements.
Maximum glandular element is present in the upper outer quadrant, sir. And
so upper outer and lower outer only you have maximum glandular element. So oncoplasty will be needed in that. So even a primary closure without drain is sufficient in upper inner quadrants. Got it?
Yes,
so
sir.
Will you keep drain or not?
Drain, sir. Hello.
Drain. Where you will keep the drain? You have done 2 surgeries, no? Now wide excision you have done, and now axilla you have done.
Yes,
so
sir.
where you will keep the drain? Single drain,
axilla, sir.
Both sides, or double drain, 2 separate drains?
So in the axilla, sir. Only.
Okay. What about the wide excision side?
Sir, since it is present in the inner quadrant, we might not need a drain.
Might not, for all breast conservation surgeries, you should not keep drain. You should not keep drain in the wide excision site. Only in the axilla you can keep. So before closing the wound, do you want to do anything else? Any markers? Have you seen any breast conservation surgery being done?
No, sir.
No. Okay. So what you do is, in the wide excision side, you will put clips, radiological clips, like the surgical clips, no? Titanium clips. You put it in 4 corners. Why do you want it to put in the 4 corners? Why you want it?
Sir, if post-operatively, if the histopathological report suggests some margin which is positive, and I want to then go for a re-excision of the margin, then the clips will help me.
No, not for that. Not for that. So why do you want that re-excision to be radiologically opaque? You can put a Prolin stitch. What adjuvant treatment is needed in all cases of breast conservation surgery?
Sir, radiotherapy is needed in all cases.
Yeah, so radiotherapy is given whole breast radiation, and there is something called boost. Boost is given in the area of local excision. Yeah, tumor bed. So once we complete the surgery, only the scar will be there. The scar will not be the same site as the primary tumor. Okay, the scar will migrate, or it will be in an eccentric position. So the radiotherapist will not know where to give the radiation. So you keep the clips, radiological clips, so that it will give you an idea to the radiotherapist where they have to give the booster radiation. Got it?
Yes.
Okay.
Sir, excuse me, sir.
Next,
Dr.
you close
Abhay,
it.
sir, you have raised your hand. Sir, one moment. Dr. Dalvi, sir, would you like
too much? I personally felt that there is too much of theoretical discussion. I just want this candidate to ask, because he's answering all theoretical questions quite well. Enumerate cutaneous manifestations of carcinoma breast.
Sir, skin ulceration, sir, nodules and powder or
Look, listen. There is a way train goes from one station to another, coursing multiple stations. If you're going to tell me ulceration, I know again you are talking from theory.
Yes, sir.
So tell me how the train goes from original station to the last station. ulceration to me is the last stage.
It travels by the.
I'm sorry, I'm derailing you
Mhm.
because you have only read theory and come, and you are answering absolutely everything that is asked in theory by you, by others. Only tell me the inspectory findings of carcinoma breast.
Sir, on inspective finding with there will be, sir, fullness will be seen. There will be involvement of the skin or the nipple areolar complex will be seen, sir.
No, will be seen means what?
There can be dimpling of the skin is.
So you tell everything that can happen.
Sir, there can be fullness, deviation of the nipple.
Okay.
There can be nipple retraction.
Correct.
There can be, sir, dimpling of the skin can be seen.
No, nipple discharge. Then
nipple discharge can be seen, sir. Then on raising the on bending forward, sir, if the cancer is fixed to the chest wall, it won't fall. The breast
again
won't
you
fall.
have gone ahead. Again you have gone ahead.
On raising the arms.
No. Puda orange.
Skin manifestations like powder orange will be seen, sir. Ulceration and nodules.
Again ulceration you came to.
Last one.
Eczema doesn't happen before ulceration.
Eczema, yes.
So you have to have, I'm just trying to come into the picture because you are talking so much good theory that clinically you are not examining the patient at all. That's your problem. And every student, that's the problem. If you sit with the patient, take history, you have taken wonderful history, examine the patient properly, you can get a lot of things out of, rather than, depending on different things. That's what is cancer curas?
Sir, it is extensive involvement of the skin, chest wall, mainly in the recurrent cases, sir.
Again, you are talking theory. So I'll ask you another question. What is the difference between ulceration and fungation? And then if you think it is ulceration, what is the diagnosis? It is fungation, what is the diagnosis?
Sir, fungation is if the overlying skin get necrosed, sir, and there is a eruption of the malignant tumor, that is fungation of the mass.
Correct.
And ulceration is an overlying skin skin involvement, sir, which causes formation of ulcer on the breast.
Absolutely. So ulceration is squamous and sarcoma, fungation is mesothelial. Do you agree with this?
Yes, sir.
How do you diagnose this clinically? So I'll give you. There is something known as probe test. I'll not give you details about it. Go ahead and see what is probe test in breast, differentiation between sarcoma and carcinoma, and you'll come to a conclusion how to come to a diagnosis. Yes. Okay. Otherwise, your presentation is very good. Theory is very good, but clinical examination is very important. With all the examiners have actually tried to, one of the examiners even told you that you're talking theory. It's not the way it goes. Unless you sit with the patient and clinically examine the patient properly, you cannot discuss different investigations. Thank you so much. Thank you, Kanagwel.
Thank you.
Thank you, sir.
Madam Maninder Chabra and Ramya ma'am, would you like to ask any more questions, madam?
No, I'm done, sir. Thank you. I think he did an excellent presentation, Yash.
Thank you,
Very
ma'am.
good. Keep it up. All the best.
Thank you, ma'am.
And take everybody's
Dr.
advice. Thank
Would you like to ask any doubts to be clarified with the national faculty here?
So it was a wonderful experience from my side.
Thank you. Good luck to you. Give my regards to Professor Abdul Qureshi, sir.
Yes, sir.
Thank you very much.
Thank you.
Friends, we have the second case discussion kindly contributed by Dr. Ishwar, sir. Dr. Jayasudha, can you switch on your video and start your presentation?
Yes, sir.
Good luck to you, ma.
Thank you.
Faculty, please take over. Make it full screen. Yeah, good luck.
Yes, sir. Thank you, sir. I'll be presenting a case presentation on ulcer over the penis. Myself, Dr. Jayasudha, postgraduate student from the Department of General Surgery, KIMS Hubli, under the guidance of Dr. Ishwara Hosmanisa and my HOD, Dr. Gurushantapa Yalagachinsa. Here I'll be presenting a case history of a 49-year-old male patient who hails from Saudati, who's a daily wage worker, who presented with complaints of ulcer over the penis since 2 months. Patient was apparently normal 5 months ago when he developed inability to retract the foreskin associated with discomfort over the penis, which was ignored. 1 month later, patient noticed growth over the glans of the penis extending till the tip of the foreskin, which was insidious in onset and gradually increased in size, which was associated with non-foul smelling, serous discharge, which was scanty in amount, non-purulent, non-blood tinged. Patient also complained of swelling in the bilateral inguinal region since 2 months, initially, which was noticed on the right side, and within a week's time, it progressed to involve the left side, which was associated with dull aching pain, which was initially of size 2 × 2 centimeter and has gradually progressed to in the last 2 months to the current size of 5 × 4 centimeters. Patient gives no history of foul smelling discharge, no history of micturition disturbances, no history of any trauma, no history of weight loss or loss of appetite, no history of cough with dyspnea or hemoptysis, no history of jaundice, no history of any bone pains, no history of high-risk sexual behavior. Past history, patient is not a known case of diabetes, hypertension, TB, epilepsy, or asthma. Patient gives history of circumcision done 2 months ago for the same complaint for which he presented to a different hospital. Family history, there's no significant family history. Personal history, patient consumes mixed diet with normal appetite and a sound sleep, bowel and bladder habits being regular. Patient is a chronic alcoholic and a tobacco chewer. Summarizing my history, a 49-year-old male patient presented with painless progressive ulcer over the penis with scanty, serous, non-foul smelling discharge with phimosis with bilateral inguinal swelling. Moving on to general physical examination. Patient is moderately built, nourished, and
Dr. Jayasudha.
Yes, sir.
Could we go to your history? Right. Right. So, what do you think is the diagnosis, or what is the differential in this patient?
With the current history-wise, I would like to give 2 differential diagnoses. The first one would be malignancy, that is carcinoma of the penis. The second one would be syphilis, syphilitic ulcer.
Why syphilitic?
A short history of ulcer, more likely I would think of malignancy, sir. But if asked for a second diagnosis, I would tell syphilis. But more likely I would go with malignancy, CA penis.
I mean, how did you specifically say syphilis? Can't it be just any sexually transmitted disease? Why syphilis?
Short history with the ulcerative lesion with lymph nodes. I would.
Is syphilis common these days?
No, sir.
Then
Not
what
very
is commoner? What is commoner then? What are the types of STD you know
of? Genital warts, syphilis, chancroid, Haemophilus ducreyi infection, Lymphogranuloma
How
inguinale.
many have you seen of gonorrhea is one of the most common ones.
Gonorrhea. Yes.
Gonorrhea and NGU, non-gonorrheal urethritis. Okay. So why do you think this patient is having malignancy by history?
Short history, which has progressed within a span of 5 months from a small.
So
lesion
is
to an ulcer.
CA penis a very fast progressing disease? 2 months you get, shortest is 5 months.
5 months, sir.
Right. Is CA penis a very fast progressing disease?
The aggressive type can progress within a short span of time.
Which
sir.
type? Which type?
High grade type, highly aggressive type can progress within a short span of time.
So they are generally squamous cell, aren't they?
Yes, sir, squamous cells. Squamous cell.
Squamous cell generally arises from a pre-malignant condition. Right. So they take a long time. Right. 5 months is a pretty short time for it. Okay. What else do you think could be the reason for it? For malignancy. Okay, next slide, please.
Yes.
No history of foul swelling discharge with phimosis, and you said that it is syphilis or sexually transmitted. Would there be discharge or not?
There will be a discharge, sir.
So that rules out fairly. Okay. Disturbances, micturition. Why do you ask for that?
So as I was thinking about the malignancy, which has progressed very quickly, if there is urethral involvement or the meatal involvement, then there'll be disturbance and micturition, sir. I wanted to rule out that. So that is the reason I asked for urinary disturbances.
No, the lesion is on the tip of the penis, or is it involving the whole of?
It is involving circumferentially, sir. Whole of the penis.
No, is it involving the shaft?
The shaft, yes, sir. It is involving the shaft circumferentially, sir.
Okay, history of trauma. Why did you ask for history of trauma? What did you rule out by this history of trauma?
Sometimes trauma will be the reason why the patient would have noticed trauma initially. Trauma would lead to maybe minor trauma, which ulcerates would have progressed.
What kind of trauma? What kind of trauma are you looking for?
Chronic trauma.
Chronic trauma? What is that? Okay, trauma can lead to phimosis. It can lead to strictures. Okay, there's been a trauma before. Jaundice, bone pain. No history of high-risk behavior, and then your differential is coming out of syphilis.
Yes, sir.
Why?
High-risk behavior for ruling out.
No, you say no history of high-risk behavior. No? So how did your differential come out to be syphilis then? You could be right. He could have got it from his wife, from his partner, right? So even if the patient doesn't have a history of high-risk behavior, it could be transmitted from the partner.
Okay.
Right? Okay. Next slide, please. Circumcision 2 months ago. Okay. So was it sent for histopath?
Yes, sir. It was sent for histopathological examination, sir.
So you can write it here in the history. That the tissue was sent for histopath, and what was the histopath report then?
Sir, it came as squamous cell carcinoma, sir.
So you write, then why are you going on? If you are getting the history that the histopath has been done and he's got a squamous cell carcinoma, why go through the whole? It's a part of your history to extract information, isn't it?
Yes, sir.
So I think it's a giveaway then. Okay. Next slide, please. Okay, anyone else, please? Okay, how does phimosis cause? How's phimosis a cause of malignancy?
Usually the growth over the glands can be the reason for phimosis.
Growth over the glands?
Glands of the
No.
penis.
So you think the malignancy is causing phimosis, or is phimosis causing malignancy?
Phimosis can
that way?
cause malignancy, sir.
So my
because of
question
the
is,
smegma.
how does phimosis cause malignancy?
Because of the smegma. Smegma is thought to be one of the cause carcinogen. It is thought to be a carcinogen for developing the penile cancer, sir.
It's a carcinogen, phimosis, smegma. No, I mean, it is that that phimosis causes chronic infection. Smegma is not a causative agent. It's not. It doesn't cause. It is the chronic infection which causes pre-main conditions, melanopostitis. Right?
Yes, sir.
Sir, please, anyone. Okay, if there are no questions, we'll move to your examination.
One question I want to ask.
Yes,
you
ma'am.
said, you said that patient does not have any urinary symptom. You asked the history of urinary symptoms. Patient has already phimosis. Then what other symptoms are you asking for? How will you differentiate involvement of urethra when the patient has already phimosis?
Ma'am, phimosis was only inability to retract the foreskin, and it was not associated with any urinary symptoms because the meatus was free.
You should be specific about what symptoms you are going to ask.
What symptom will differentiate involvement of urethra with just phimosis?
Poor urinary stream.
So that will be in both
Dribbling.
phimosis as well as involvement of urethra. What else?
Phimosis. If phimosis, there'll be ballooning of the.
That will be there in the matter. What about what will you see in the urine?
Blood stained or clear urine?
If the urethra is involved, there'll be blood-stained urine.
So did you ask for that? I think that was a very nice.
What part
didn't
of
ask.
And also what part of urine gets stained? Is it the initial part or is it the whole?
Initial hematuria, terminal hematuria, total hematuria.
Initial hematuria, sir. When the fossa navicular and the meatus is involved due to carcinoma, initially there'll be hematuria and later turns out to be clear.
Yeah. So the point I want to draw is that you should be asking more in depth about the urinary symptoms.
Yes. Okay, ma'am.
Dysuria also many times will be there. Not only hematuria, dysuria also sometimes.
Dysuria and hematuria.
Yes, sir.
Should we go to the examination?
Yes. General physical examination. Patient is moderately built and nourished, conscious oriented, pulse rate of 80 beats per minute with a BP of 110/70 millimeters of mercury, respiratory rate of 20 cycles per minute. There's no pallor, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy, no pedal edema.
Dr. Jasuda, just a second. I think Dr. Dalvis raises his hand, sir.
Yeah. Jasuda, tell me embryological origin of the urethra and the prepuce.
Sorry, sir.
So one comes from another endothelium, urethra, and the prepuce comes from where? Ectoderm. So when you talk of malignancy in and around the penis, I'm not an expert in this at all because I don't practice urology. But I'm just trying to tell you, if you think of the origin and embryology, everything becomes clear what history to take and what history not to take. Thank you so much.
Okay, sir.
Yeah, go on, Jesse.
Yes, sir. An ulcerative lesion of size 6 centimeter extending from the tip of the penis till the mid shaft, involving the entire circumference of the penis, which with irregular margins, everted edges, floor is covered with slough tissue. There is serous discharge that is noted, and the surrounding penis around the root is found to be edematous. There are multiple nodules noted over the shaft of the penis proximal to the ulcer, with largest nodule measuring 1 × 1 centimeter with ulcer over the surface of the nodule. External urethral meatus appears normal. Scrotum appears to be normal. There is a swelling of size 6 × 4 centimeter noted over the right inguinal region with smooth surface, well-defined margin over the swelling. Skin over the swelling appears to be normal. And a swelling of size 3 × 2 centimeter noted over the left inguinal region with smooth surface, well-defined margin. Skin over the swelling appears to be normal. This is the lesion, sir. These are the nodules. On palpation, ulceroproliferative lesion of size 6 centimeter extending from the tip of the penis till the mid shaft, involving the entire circumference, which is tender with irregular margins, everted edges. Base is indurated. Induration noted all around the ulcer till the root of the penis. Bilateral testes and scrotum are normal to palpate. And in the inguinal region, a swelling of size 6 × 4 centimeter noted in the right inguinal region, which is tender, firm in consistency with smooth surface, well-defined margins, and immobile. And a swelling of size 3 × 2 centimeter noted at the left inguinal region, which is tender, firm in consistency with smooth surface, well-defined margins, which is immobile. Cardiovascular system examination. S1, S2 had no murmurs. Respiratory system, bilateral normal vesicular breath sounds present, no added sounds. Abdomen is soft, non-tender, no organomegaly. Rectal examination is normal. CNS examination is normal. Summarizing the case, a 49-year-old male with complaints of ulceroproliferative growth over the penis since 2 months and bilateral inguinal swelling since the last 2 months. On examination, an ulceroproliferative lesion noted over the tip of the penis, extending till the mid shaft with irregular margins, everted edges, floor with slough, indurated base, and surrounding induration with bilateral inguinal lymphadenopathy.
Okay, Dr. Jayasudha. A couple of things I just wanted. Do you think this is a high-grade tumor or low-grade? Just by history and examination.
A high-grade tumor, sir.
Why? Why?
History, short history.
No, history is not.
Examination, the ulcer, which is almost involving 3/4 of the penis circumferentially with induration that is extending till the root of penis, and bilateral lymph nodes are involved, sir.
Okay, I'll just put it more clearly. Malignancies involving the prepuce and the glans are generally low grade. Those involving the shaft are high grade. Okay, why do you think this patient is not having, does he have any urinary symptoms?
No, sir, he doesn't have any urinary
Why?
symptoms.
Why do you think the whole thing has been destroyed, yet he doesn't have any urinary symptoms? Why?
The corpora spongiosum is not involved clinically as because according to history, it is not. He doesn't have any urinary symptoms.
So if the corpora was
urethra
involved,
is not being infiltrated.
No. If the corpora was involved, he would have had urinary symptoms.
If the urethra was infiltrated,
then he would have urinary symptoms. Patients of CAPNs hardly have any urinary symptoms obstruction. Urine always finds its way out. Okay, so
yes,
even if the urethra is involved, he may have hematuria, he may have dysuria, but will not have urinary symptoms, obstruction. Right. It's very rare. Okay, so what's your diagnosis now?
I would like to put my diagnosis as carcinoma of penis with bilateral inguinal lymphadenopathy, sir. Stage 4.
Why stage 4?
Bilateral inguinal lymphadenopathy, which has fixed nodes, that is multiple nodes involved. So it will be N3 with T3 clinically and M0.
Okay. So how will you proceed then?
Since it's a stage 4 tumor with CN3, sir, I would like to give neoadjuvant
No,
chemotherapy.
no. How have you decided that it's stage 4? How do you have it decided it's squamous cell carcinoma?
Sorry, sir. Yes, sir. The circumcision was done and it was sent for HPR investigation.
So you said it is a T3 tumor, N3. Is it a stage 4? What is stage 4 carcinoma penis?
Any T staging with N3 and any M stage, sir.
What is the M stage here?
M0, sir.
So
N stage.
it is T4, N0 only will become under the stage 4. Any T only with the M1, it comes under the stage 4. If it's the T4, N3, M0, you can say it is a stage 4. With the T3, N0, M0, N3, M0, it is not stage 4. It is only stage 3B.
3B. Right, it's stage 3B.
It must be a stage 3B.
Okay, sir.
So what is T4?
T4 with N3 and M1.
No, what is T4? What is T4?
T4 is
Isolated, sir is asking isolated T4. Forget about the lymph node.
yes, sir. T4 is when there is extra
Local invasions.
Involvement of adjacent structures.
When the prostate, the scrotum is involved, then it is T4, sir.
Prostate,
scrotum and the prostate.
Pubic bone, there is a bit is penetrate to the bone. Also, you are going to make it as a. You have examined the abdomen?
Yes, sir. Examine the abdomen, sir.
For what?
For iliac nodes, any palpable iliac nodes, and organomegaly.
You said there is a node is fixed.
Yes, sir. Inguinal nodes.
Yes, but the pelvic nodes, iliac nodes.
Sorry, sir.
No, when you are seeing a fixed node, is it an indication that you will have an iliac nodes or not?
Yes, sir. There are high possibility there will be iliac nodes present, sir, when the nodes are fixed.
So you
on your examination, how do you know this is deep inguinal lymph nodes or superficial inguinal lymph nodes? Because N2 would be superficial inguinal lymph nodes, N3 would be deep inguinal lymph nodes.
So N3 more than 2 nodes involved, which is fixed. So
no, deep inguinal lymph nodes is N3. Isn't it?
Any fixed node is T3 or deep inguinal node. If there is a crocket node is involved or a pelvic node is involved, it is also there. That is what the indication. When you have a fixed node, it always indicates that it is going to be
N3.
So it is usually done by ultrasound. You can't just do it clinically. Okay, you can just say that they are fixed and the chances of it, but it's better to do an ultrasound.
One more is the horizontal nodes are there.
When you have a node, and what percentage of the node is possibility malignancy? Is it because this can an infection produce such a node?
Yes, sir. Because the ulcer is very huge, there can be reactive lymphadenitis also, secondary to infection over the ulcer, sir. So it can be reactive lymphadenitis also.
Why you done PR for
So sorry, sir.
Bilaterally, the lymph node is involved.
Yes, sir. Bilaterally involved, sir.
What group of lymph node is involved?
The inguinal group of lymph nodes are involved, sir.
Vertical, horizontal.
Horizontal, sir.
How will you divide the horizontal group of lymph nodes?
Supromedial, suprolateral, based
Cabana node.
Node of Cabana is the sentinel node draining the malignant side. It is supromedial to the insertion of GSV to the femoral vein, sir.
So you are sure there is no metastasis, no, in this case?
No, sir. No systemic metastasis. No.
Why you done PR for this patient?
So when sometimes retrograde spread of tumor, there will be deep pelvic nodes that can be appreciated in rectal examination, sir.
What is clocket node?
Node of Clocket.
It is in relation to the my earlier question.
Sir asked in a different way. I'm asking in a different way too.
You know the femoral canal.
The medialmost compartment of the femoral canal is the Clocket node.
Any significant of Clocket node? Can I only Clocket node involve without knowing involvement of the internal nodes?
The glans of
the
glans penis
small,
drains into the Clocket nodes.
directly it can go.
Directly into the Clocket nodes.
Right. Okay. So now what will you do? Got a histopath report?
Yes, sir.
Right. And you've
I
got the
would.
patient.
Yes, sir.
What the biopsies you have taken?
So circumcision was done, sir, because he presented with phimosis, and an excision biopsy. Excision of that was sent for HPR, sir, which came out as squamous cell carcinoma, sir. And FNAC from the inguinal lymph nodes were done, and it has come as metastatic deposits of squamous cell carcinoma, sir.
What type of squamous cell carcinoma? Sir has asked, no? Sakai sir has asked you what grade. Did they mention anything about the grade?
No, sir.
Okay, what are the grades? What is Broder's classification?
More poorly differentiated, well differentiated, and
Abides, the sir is still raising the hands.
Yeah, I just want to ask, in pathology, what do you see classically under microscope squamous cell carcinoma?
Sir, keratin pearls, sir.
What do you mean by this?
The number of keratin pearls, the well differentiated.
No. What is a keratin pearl?
It is.
You just can't answer from theory. Tell me what you saw in pathology as a keratin pearl.
Eosinophilic wall-shaped deposits around which the cells are arranged in clusters.
No. What does it tell you? I mean, this is stratified squamous epithelium, isn't it?
Yes, sir.
So what happens in squamous cell carcinoma? What does it mean, keratin pearls?
It is well differentiated.
No, it means that the squamous cell carcinoma, the squama has infiltrated into the dermis. That is why it is infiltrated, right? It is a differentiated thing. It has also infiltrated the basement membrane, gone into the dermis, right? It means that.
Okay.
And if it is undifferentiated, you will not see.
Can you describe the keratin pearl? How it looks like?
Sorry, sir.
Keratin pearl, how will it look like in the histology?
Eosinophilic wall.
Have you seen a picture with a keratin pearl there?
Yes, sir. Yes, sir.
Yes, sir.
So can you get a squamous cell carcinoma without keratin pearl?
Yes, sir.
So now non-keratinized.
Non-keratinizing squamous cell carcinoma, which is not very common, sir. Onion like world appearance, onion skin appearance.
In keratin pearl. Onion.
Do not utter words which will stimulate examiners to ask you further questions.
So let me go into a different structure now.
Now see, Dr. Jailal will come in. Dr. Rajan is waiting. Don't utter words which will, stimulate examiners to ask you. It's always let the ball be in examiner's court rather than in your court. Now you have opened the arena. Jailal, please go ahead.
So where do you get onion appearance? No? Have you heard any sarcoma? Okay. So histology is very important. Usually in our PGs, in our setup, we are not giving much importance. Most of the Western examination, if you are MRCS and all, a lot of things are going on pathology, or whether you are going to appear for USMLE. The questions are mostly on the pathology, histology. They are going to ask a lot of questions. So please have the habit of not just reading the report, see the picture, and if possible, go to the pathology lab and see the slides. You need to look in at least many times so that you will be able to familiarize with that. So not just superficially saying something.
In penile carcinoma, the lymphovascular invasion and perineural invasion also is taken into consideration as far as the differentiation of the malignancy is concerned. So that also you have to mention about that. Further subdivisions.
Yes.
What are the new changes has come in the staging, stage 8, AJCC 8 stage?
Yes, sir.
What are the changes in the AJCC 8?
T2, T3, T2, which involves only the corporate.
It is TIS.
TIS plus carcinoma in situ, sir. TX.
What other carcinoma you get TIS staging?
Which are the in situ?
In situ is different. The TIS is coming as a separate staging in a carcinoma penis. It is non-invasive localized squamous cell carcinoma.
TA is non-invasive squamous cell carcinoma, sir.
Any other carcinoma you know which has that TA stage? Only that is, as far as I know, it is only 2 carcinomas we get that. One is that transitional cell carcinoma of the bladder. That staging also you put as a TA, but most other carcinoma we don't get that staging as a TA. So that is a changes which has coming. What happened to the T2 and T3? AJCC 7, AJCC 8.
Yes, sir. T2 in AJCC 8, it says involvement of there's infiltration into the corpora cavernosa, sir. And T3
spongiosa. Sorry, it is spongiosa. T2 is spongiosa, and
so
T3 is cavernosa.
Spongiosa.
No, AJCC 8, it is spongiosa is AJCC 7, this is a corpora cavernosa. That is a change which is coming in there.
Yes. Earlier, spongiosum is a late involvement, but nowadays, according to the new classification, spongiosum is called as T2, whereas the corpora has a T3.
Corpora has become a T3.
Right. And TA means it is a pushing kind of malignancy. TA means it's a pushing kind.
How we are going to proceed?
So we got USG done, sir, and then CECT. Which showed it is suggestive of penile malignancy with inguinal lymphadenopathy. Excision biopsy also came as squamous cell carcinoma of the penis with metastatic deposits of carcinoma. So now I would like to proceed with neoadjuvant chemotherapy, sir, and then later go take up if the tumor regresses, surgery, otherwise a palliative surgery.
What is your intention of starting chemotherapy here?
So fixed inguinal lymph nodes, sir. So
your chemotherapy for the node?
No, sir. The tumor also will regress. The tumor also.
So what you are going to do if the tumor is regressing?
Total penectomy with urethral diversion, periurethral.
What is the plan now? Per se, the T3 tumor, you are going to do the total penectomy. So the chemotherapy is not going to make it as a partial penectomy.
No, sir. It will be total penectomy.
What is the intention? Only when it is inoperable, we are saying, or in the early stage, then there is an indication for you starting on the chemotherapy. And for the node, are you interested for a chemotherapy or your interest is for radiotherapy?
Radiotherapy, sir.
So how you are going to plan your management? Do you want to do any MRI investigation or CT is enough for you?
For the nodal status, CT is enough, sir.
Yes. In the early stage,
No.
the classification comes the lymphovascular invasion. So
Dr.
T1.
Dr. Jayasudha,
Yes,
what
sir.
are the factors which you need to know before you take a suggestion for surgery or for chemo or for radio? What factors do you have to know?
If the pelvic iliac nodes are involved.
No, first is the tumor, second is the nodes, and third is the metastasis. Right? So for the tumor, for the penis, what do you need to know?
If there's perineural and lymphovascular invasion.
You have to know how much of the shaft is salvageable. Right?
Yes.
So how do you know that? Is there involvement of the spongosa, the cavernosa, and the urethra? So how do you get to know this?
All the soft tissues, what is the best investigation?
MRI, sir. MRI.
Can you do an ultrasound for the soft tissue?
Yes, sir. Ultrasound also will give us the depth of invasion.
So do you do an ultrasound of the penis in CA penis?
Yes, sir.
You should have you seen it? Usually not done. You get an MR.
For your inguinal nodes, that is fine. So here the investigations are both different. The treatment is also different. But
okay, so you want to know whether how much of the distal shaft is salvageable, whether the spongosa and the cavernosa is involved, and whether the urethra is involved. Now, what about the lymph nodes?
CT would be a better modality for the lymph node status. So CT abdomen.
So which lymph nodes are you looking for now?
The iliac nodes.
The inguinal, the iliac, and the other pelvic nodes.
Yes, sir.
All pelvic nodes, okay. And for metastasis?
Extra pelvic nodes like para-aortic intercaval nodes.
So there you get an ultrasound abdomen, you get a CT chest, you get a CT pelvis done, and you get a PET scan done.
Normally, remember this is like a squamous cell carcinoma. Invariably, it is a loco-regional.
Semi-local.
This carcinoma, it will not produce a multiple systemic disease, is very rare, like oral carcinoma. And squamous cell carcinoma of the penis is also loco-regional. Your more intention is locally. Yeah. What is the difficulty in doing an MRI also for the penis? Or what precaution you should take when you are taking?
MRI with the penis in the erect position.
So,
for better soft tissue.
So how do you do that?
There is prostaglandin E1 that is injected, intercavernal injection of prostaglandin E1 causes artificial erection.
So that is mandatory to get it done. So when you are sending the case for MRI, not just you can't write, you need to know about that and you have to send it in an appropriate way. And what is the clinical? You found out induration, no?
Yes, sir.
Induration is going up to what?
Up to the root of the penis, sir.
So what does it mean?
Clinically, lymphovascular invasion can be up to the root of the penis, sir.
The margin, if at all you are going to calculate, it is up to the level of storage.
Yes, sir. Margin clinically is calculated from the induration side, sir, not from the ulcer edge.
So if at all, what chemotherapy you said? Use chemotherapy. What chemotherapy you will start?
Based on the new guidelines, TIP regimen, sir.
So if node is now T3, N3 node. How we are going to manage the N3 node?
Bilateral inguinal block dissection, sir, with total penectomy.
Fixed node.
Sir?
Such a large fixed node, you are going to do the node dissection.
Sir, after chemotherapy, then we'll plan for total penectomy with diversion perineal urethrostomy with bilateral inguinal dissection, sir.
So now the most better is you use a chemoradiation. The radiation is more important than chemotherapy here. So chemoradiation is ideal. If at all you want to do the chemotherapy also, chemoradiation is a better option. So what type of lymph node dissection you are going to do?
Do you have superficial nodes are involved or deep nodes are involved in this case?
Deep, sir. Both superficial and deep nodes will be dissected out.
So what sort of lymphadenectomy would you like to do?
We have two nodes,
Yes.
modified Carcinoma method and what is brushless triangle, quadrangle. What is the boundary of
the
boundary of your dissection?
Medially, the lateral border of adductor longus. From there to laterally the sartorius, superiorly the inguinal ligament, and the apex of the femoral triangle inferiorly, sir. And base over the pectineus, up till the pectineus.
That is very
you don't want to do for the ideal lymph node, or you will confine to the only inguinal?
Only for the inguinal node. So it is always a ilioinguinal dissection, no?
So there is what is known as dressless quadrangle.
So you said that clinically external iliac lymph nodes are also involved. Even otherwise also, when the deep lymph nodes are involved, it is always a ilio-inguinal dissection, not only an inguinal dissection.
Okay, sir.
Then what is the boundary for inguinal iliac dissection then? You said about the boundaries for the inguinal. What about the iliac boundaries? How far you have to remove them?
Ilial, if the ilial dissection is also to be done, medially up till the bladder, laterally the obturator nerve, superiorly the bifurcation of the iliac vessels.
Only obturator nerve. Obturator nerve, we are going to see. Obturator nerve.
Yes, sir. And
genitofemoral nerve.
Obturator nerve, sir. And inferiorly the obturator foramen.
For the bifurcation.
Yes, sir. Upper limit up to the bifurcation of the iliac vessels, sir.
Okay. So normally obturator nerve you don't see at that level. Genitofemoral nerve, and you can come here down and remove that. So suppose you have done a superficial inguinal dissection, what will make you to go for a iliac dissection? Any criteria you have? Or?
If deep nodes are involved, then we will go ahead with the
deep node. What is the indication to go for a deep node dissection? That's what sir asking.
You have done only a superficial node. You are saying that, and is there any indication for you to go for the deep also?
If more than two nodes are involved while doing a superficial node.
That is clinically. Is there any objective confirmation? That is subjective. Two nodes are involved. That is also indication.
Frozen section.
Frozen section. So you have to send for the frozen section, and if it is there, you have to go for that. So here you are going to do with a 2 incision or a single incision?
So if we are planning for ilio-inguinal, we can take a single incision, sir.
This node, you need to only plan like that. Ilio-inguinal only you have to plan. You can't plan only when you have a desired node or suspicious of the node. Then you can think of starting with a superficial inguinal dissection, then go for a ilio-inguinal dissection. This is already an established case, and the deep node is involved. You are going to give a radiotherapy or chemotherapy, and later that you are going to do that. You are going to involve for bilateral?
Yes, sir, bilateral, sir. Clinically, bilateral is involved, sir.
What is modified operations or the Carcinoma operations?
Carcinoma operation, the lateral boundary is restricted up till the femoral artery.
Good. So you don't go as per the dressless triangle, very laterally you don't go. All you are going to do, and you don't cut the saphenous vein also. You will keep that, and that will be reducing that. What is the most important complication?
So, complication of?
Inguinal node dissection.
Block dissection. Block dissection.
You run a block dissection. What are the complications you are going to expect?
Flap necrosis,
Okay.
Then
lymphedema.
Lymphedema. When you talk about the cervical neck node dissection, what is the complication?
Injury to the great vessels, femoral vessels.
After surgery. What is carotid blow?
So when there's infiltration of the vessels, there'll be torrential hemorrhage from the
blowout concept.
How do you prevent? Is there any way to prevent them? The blowouts at the
flaps, sartorius flap. We can cover the vessels with sartorius flap, which can be sutured medially.
Very good. You can split it or disconnect it, and you can the flap well. So how will you prevent the lymphedema formation? Is there any way you can mitigate the lymphedema formations? What are the precautions you will take when you are doing a surgery? So that is also one of the, I mean, this is more, when you are using it, it is a practical question, but for a postgraduate, it is one of the questions asked in the theory also, mitigation methods. Starting from the way you are going to operate. Also, endoscopy procedure instead of the open procedure, you can go for endoscopy procedure. There are a lot of now plastic beads are coming in. You can put it inside. And infection is the most important complication. It promotes the formation of lymphedema. So how to prevent infection? Starting from with putting the bandage of the wound. If you are going to put a very tight bandage, that is going to cause again edema. So all this is important that you can go and read. This is how you are going to prevent the lymphedema complication. So total penectomy and how you are going to make the perineal ureterostomy?
Around 2 centimeters of the urethra is left from the where the
anatomical layers of the penis.
Yes, the skin, the subcutaneous tissue, the buccal fascia, tunica albuginea, the corpora. So,
Dartos fascia.
Dartos fascia, and then the buccal fascia, the tunica albuginea, the corpora, dorsally the corpora cavernosa, the 2 corpora cavernosas, and below ventrally the corpora spongiosum, with the urethra in between, running in between the corpora spongiosum.
it traverses, not running in between. It traverses the spongiosum.
Yes.
How will you identify the urethra while doing the surgery?
Sir, sorry, sir.
How will you identify the urethra while doing the surgery and harvest it for urethra stone?
So have to cannulate the urethra.
My question is identification of urethra. How will you identify? Have you ever seen a surgery of penectomy?
No, sir.
No, I've seen a total penectomy. So probably this case you can go and assess.
It looks blue in color. It looks blue in color when compared to the other tissue. Okay. So with which we can say it is a urethra. Then, as you said, you can divide and can catheterize with police to secure it before going towards penectomy. Okay, what is the commonest mode of death in this kind of patients?
Torrential hemorrhage due to femoral blowout.
Yes. Hemorrhage due to femoral blowout.
Femoral blowouts.
Or if the disease, if the node is fixed to the femoral vessels, that may lead again to torrential hemorrhage. That is how the patient commonly dies. Okay.
Yes, sir.
So suppose this patient has come to you in an early stage, when you before you have done a circumcision and early stage, it is only in the glans finis. Do you have any other surgical, any other treatment modality is available for the patient?
Yes, sir. If only the glance is involved with induration also, which is confined to the glance, glancectomy can be done with surveillance. Or if only a part of shaft is involved and we get adequate margin of 2 centimeter from the root, then partial penectomy, we can go with partial amputation of the penis. Based on how the nodes are involved, we can go ahead. If the nodes are involved, sentinel lymph node biopsy, and if nodes are involved, we can go with inguinal dissection. And then surveillance.
Who has identified the sentinel node biopsy?
Sir?
Who has identified the sentinel? I mean, who has implemented the sentinel node biopsy and where?
Cabana.
Yeah, Cabana has practiced the sentinel node biopsy in the inguinal region first. Okay, now we are using it very commonly in the breast rather than in the inguinal region, where it is not commonly used now.
Oh, the evidence is not for Cabana node be the first node. In the earlier presentation, you said smegma as a carcinogen. It is absolutely wrong. Smegma is not at all a carcinogen. That's a smegma.
Chronic infection.
It produces irritation. That's a raw injury. Most of the time, it's a human papillomavirus that gives an opportunity for the human papillomavirus to enter and produces a carcinogenic agent.
Yes.
Not because of the smegma.
Yes, sir.
Any non-invasive procedures, non-surgical procedures.
When early lesions, when they come with pre-malignant or early lesions, topical 5-fluorouracil creams can be given. Laser ablation.
How many
Any modality of local radiotherapy?
Yes, sir. Brachytherapy, yes, sir.
What is the indication of brachytherapy? What is the indication of external beam radiotherapy?
When the tumor size is less than 2 centimeter.
2 centimeter. It's up to 4 centimeter, you can go brachytherapy. When the tumor is more than 4 centimeter, you have to go for a external beam radiotherapy. The third indication is a fixed lymph node. So at that again, the radiotherapy has a place. 5-fluorouracil cream, how many days? How long? You are not aware. Okay, no problem.
It is not very often used, no, sir. At least I have not seen YFP being used. It's very early disease.
Only in the early stages.
What is Bowen's disease? Dr. Jayasudha, what is Bowen's disease?
Very flat early lesions.
Or rather, it's known as, it is known as, in penis, it's known as?
It's carcinoma in situ, sir.
In penis, it's known called?
Sorry, sir?
In penis, it is called? Erythroplasia of?
Erythroplasia of curette.
So this is where you use 5-FU creams.
What is the difference from Bowen's disease and erythroplasia of Corette and Paget's disease?
So all are pre-malignant conditions, sir. Bowen's disease is the pre-malignant lesion that is involving the shaft of the penis. Erythroplasia of curette involves the glans of the
common site of Bowen's disease? In the penis, what is the commonest places?
The trapezoidal skin, sir.
No, it's not a disease of disease of the.
It's on the skin, anywhere on the skin.
Anywhere on the skin you can get. In fact, the shoulder, all that areas you can get.
Usually actinic areas where there is exposure to sunlight.
Sunlight areas you will be able to get. If it is getting in the shaft of the penis, it can happen in the penis. If it is happening only in the glands, it is called erythroplasia of Corette. Can you get a Paget's disease in the penis?
Yes, sir. It is the cutaneous manifestation of the adenocarcinoma of the Tyson's glands. There'll be Paget's disease, sir.
Tyson's gland? No. It always means, see, it is a sweat gland. Breast is a sweat gland.
Apocrine sweat glands of the penis.
It is glands. Glands, you can get extramammary Paget's disease, you can get erythroplasia of Corette, you can get Bowen's disease, but all are cutaneous manifestation of the underlying malignancy. Paget's is adenocarcinoma, Bowen's and erythroplasia of Corret are squamous cell carcinoma.
Now, Bowen's
What is
disease and
BXO?
erythroplasia of Queret are different because Bowen's is because of exposure to sunlight. You can't have exposure to sunlight on the penis. So it is called erythroplasia of Queret, which is because of HPV. It can be because of infections. It can be because of chronic irritation. Right? These are the causes. So that's why it's given a special name called erythroplasia of Queret. Elsewhere, it's called Bowen's disease.
Okay.
Should we call it a day, sir?
Yes.
My will, sir.
I think Jayasudha, you have done well. We must thank Ishwar sir for molding you to this level, and because it is very difficult for you as to present a case of a penis case, and you have examined it clearly. That is a good sign. It's not talking only on the theoretical part. You have examined the case and adequately are presenting the case. Keep it up.
She was asked to present at the last moment, sir. At 5 p.m.
Sir, in fact, I should put on record.
That is
She
now
was
become
given
like a
22
Karavel
hours.
style.
No, sir. Somebody withdrew, so I had to resort. But she was supposed to present next week, sir. That's what sir has agreed earlier. But then she took,
next week another case. Next week is another case. This case is instantly agreed for today's presentation.
So it was a real life examination for you.
More or less.
So, Jayasudha, I think we will give you the chance. If you have any doubts or comments or any doubts to be clarified, you can ask.
Yes, sir. I would like to thank everybody. I would like to specifically thank Ishwar, sir. Though it was sudden, this was a really good experience, sir. Thank you, sir. Thank you, sir. Thank you, Kanagvel, sir. Thank you, everybody.
So, faculty, we'll call the session a close. Thank you, Ishwar, sir. I think other
Thank you, sir.
faculty
Thank
are
you.
there. Kanna, sir, would you like to tell Ramya ma'am, Maninder ma'am?
Yes.
Ibrahim, sir? Yes, ma'am.
Good evening, everyone. I think she has done very well for, especially knowing that the case was allotted in the evening and a real life kind of scenario. And the history part, I think, should have been more in a chronological order rather than the history of circumcision coming in the past history or later half of the history. So that is something I would like to say.
Yes, ma'am.
Ashok, sir, would you like to add something? Thank you, Maninder ma'am, for joining. Wish you could join us more often.
Yeah, I'll definitely join. Thank you for inviting and thank you for giving me the opportunity.
Sure. Ramya ma'am, thank you. Ibrahim sir, thank you. Kanna sir, thank you, sir. Jailal sir, Karnakaran sir.
Thank you, sir.
Rajiv sir, thank you everyone. Ishwar sir, thank you.
Thank you, sir. Thank you very much to everyone.
Thank you
Thank you very much. It was a nice opportunity.
Thank you very much.